It is indeed a huge privilege for me to be able to participate and introduce Shanta. But before that, I have to say that Professor T.N. Srinivasan left a huge mark on many, many students. I am a dropout from Delhi school, but I think I would have dropped out earlier if it hadn't been for the influence of people like Professor Srinivasan. And I remember when I met him for the first time, I said, "Sir, but you are a textbook." I had no idea that you could actually be here in person. Wonderful, wonderful life of not only path-breaking research, but also of influencing many, many students across India and abroad in turning to issues of economic development that perhaps they would not have otherwise. To Shanta, it's also a huge pleasure, Shanta, to share the stage with you. We have known Shanta for a long time, followed him since his WDR, I believe 2004 maybe, which still is perhaps one of the most cited WDRs that we have. And I think that he hasn't lost track of, I think, the main work that they did right now about how to make things work for the poor. And I suspect we are going to see a lot of that in today's chat as well. I don't want to be between Shanta, your lecture, and the crowd. So over to you. And I think, as Karthik said, 35, 40 minutes. And I'm sure we will all be telling you when you have to stop. So over to you.
Well, thank you very much. Thank you, Rukmini, for that fulsome introduction. And I'm delighted to be here. It really is a real honor to give this T.N. Srinivasan lecture and also to speak at Poonam's first IPF. But I also want to add my thanks to Shekhar Shah, who I think had something to do with my being selected as the T.N. Srinivasan lecturer this year. And as Karthik mentioned, T.N. was a giant in the profession, but he also was a good friend and a really a true academic. I should say he's also a lively sparring partner. We've had lots of discussions. And I want to add that not only did he insist on data, but he also insisted on rigorous economic theory. And in fact, many of our discussions was about the theoretical foundations of general equilibrium models and things like that. But as I said, T.N. has always been a longstanding friend, and I can't resist telling you one anecdote of our long friendship. And I met T.N. because he was working with Clive Bell, who is somebody that I was collaborating and have been collaborating with over the years. And one day I asked T.N., I said, how come, all your co-authors names begin with B, Bhagwati Srinivasan, Bardhan Srinivasan, Bell and Srinivasan. And T.N. said, oh, that's because it's all BS. And that is an example of his self-deprecating humor as well. So I'm in this talk, I'm going to talk about COVID-19 responses in the midst of market and government failures. And I confess I'm going to be doing something that T.N. used to call intellectual arbitrage, which is that I know something about market and government failures. I don't know that much about COVID-19, so I'm going to try to map something I do know into something I don't know. And just to say that I realize that the responses to COVID-19, especially if it's an emergency, is not the kind of thing where you have to worry about market and government failures in an emergency, and some policies might be undertaken despite the existence of them. But I think it is really important because these market and government failures might circumvent or be counterproductive in what we're trying to achieve. And secondly, let's look at this as an opportunity to correct some of these market and government failures in the long run, especially in the post-COVID era. And much of what I'm going to say echoes some previous IPF speakers, and I see Lance Pritchett is here and my colleague Jeff Hammer's work. But also I'm pleased that some of the themes that I want to cover are echoed in some of the papers coming forward in this conference, in particular the data session that follows this one, as well as N.K. Singh's session on federalism and COVID. So let me now share my screen. Okay, so let's just start by saying that, you know, COVID-19, and lots of people have written about this, is a clear case of a market failure. It's a classic case of a market failure. And what is that? Well, because it's an infectious disease. So you can think of it as there's a market for social mobility, you know, people moving around, going to restaurants, going to traveling on buses and so on. And there's a demand for that social mobility. And there's a supply, which is the cost of a social mobility. And if people are left to their own devices, they will choose a level of social mobility, Q star, that balances their marginal cost and their marginal benefit. But because this is an infectious disease, every time you move around and interact with other people, you're likely to infect other people. In which case, your social mobility has a social cost over and above the private cost to you, which is why we have a level of social marginal cost that exceeds the private marginal cost. And therefore, the socially optimal level of mobility is Q double star, which is less than the privately optimal level. And the point is that we need to find some way in getting individuals to behave as if that was the social marginal, the cost was the social marginal cost in order to achieve this optimum. Now, this is just, you know, simple Econ 101 theory, and it's pretty much accepted throughout. The interesting thing is we almost never have quantitative estimates of that wedge between P double star and P star, or the extent to which the social marginal cost exceeds the private marginal cost. We accept that it's higher, but the quantitative estimates, and this comes back to one of TN's themes, is that for policy, we need to know how much, because we need to know by how much we should restrict social mobility. Now, there's some good news here. At least for the US, there are these two professors at University of Virginia who have actually tried to estimate it. And they find that the cost, they calculate the private cost, because the private cost includes the fact that you might get infected. So that's about $82,000. And the social cost is about 4 times that amount, which gives you an idea of the magnitude of that wedge and the magnitude of the externality associated with it. And that depends on whether you include testing or not. So there is some basis for the kinds of government interventions that we would like to see. So then let's look at what governments actually, before that, let me say that this is a pure efficiency argument for government intervention. There might be also an equity argument. And that is that there is some evidence in other diseases that infectious diseases adversely affect the poor, even more than non-infectious diseases. So this is some data from China on the adult mortality rate from infectious diseases and non-infectious diseases. And you see that the poorest quartile is several times more likely to suffer mortality than the richest quartile. And it's the same thing with India. You look at, there's a comparison. You compare TB, which is an infectious disease, or malaria, with something like blindness. And you find that these are TB and malaria are, again, a much higher incidence among the poorest decile. So there's an efficiency argument and an equity argument for government intervention in the face of COVID-19. But the question is, how are governments actually intervening? What are they actually doing? And you look around the world, including in India, and I'm going to focus a lot on India and or South Asia and Africa, partly because these are the regions that I know best, but also because these are regions where the pandemic is still raging, if not likely to get worse. You look at governments around the world, and what they're doing is they're increasing their spending, the health spending, on hospitals or treatment. It's the treatment of people who are affected by the disease. Now, the rationale for this is completely different from the rationale that I put up earlier about the infectious disease. The rationale here, why governments spend on hospitals, is because there's an insurance market failure. Either governments don't have the capacity to regulate insurance markets, or the insurance market just doesn't exist. And as a result, there's an efficiency argument for government to actually provide hospitals. And therefore, you need to pay for those hospitals. But this is where we begin to see that there's a potential government failure. Now, there's a good efficiency argument, keep in mind, that you want, if you're paying for hospitals, that you want to locate them in urban areas where there's a concentration of population. And that will tend to be where rich people live or non-poor people live. And that's where the efficiency argument might run up against the equity argument. But let's just look at the facts, right? So in India, if you look at the total distribution of healthcare subsidies, you find that the overwhelming majority goes to the richest quintile. It's about 33% compared to less than 10% to the poorest quintile. And it's not just India. This is also the case in most of sub-Saharan Africa. So you look at you compare the hospital care, the subsidies going for hospitals between the richest and the poorest quintile. And there's no country in Africa where the poorest quintile gets more than the richest quintile. And in some cases, the richest quintile gets about 4 times as much. Now, as I said, there is an efficiency argument, given that there's an insurance market failure, for locating hospitals in urban areas, and they're more non-poor in those urban areas. But there is a problem, because you also see that since rich people and poor people have need for catastrophic care, you can always get a heart attack and you need to go to a hospital, the rich, having more political power, might be able to locate hospitals nearer where they live. And they also might actually use the hospitals, and this is the real problem, they use hospitals in a way that's beyond catastrophic care. And they use it for regular care as well, because they're located nearby. And as a result, again, the poor lose out because they don't have access to it. So there's a crowding out. And this is a message I want to I'll carry through, which is when you start providing what are essentially private goods cheaply or for free, it gets captured by the elites. They have more political power, and you're providing this private good to everybody, they can capture it much more quickly than the poor can, and the poor lose out. Now, this is mainly about hospitals, but you notice that there is a second side to this, which is if you look at primary health centers, those are much more evenly divided. The spending is much more evenly divided. In fact, it's in favor of the poor because they're usually in rural areas, and they're in areas where the poor live. And this is also true in Africa, where the distribution of primary facilities is a little bit more, in some countries, is a little bit more favorable towards the poor. But this is where we run up against the next problem. Oh, I forgot to mention one thing. Sorry, I added a slide last night. So I thought you might be interested, which is this potential for political capture, which is what we're talking about earlier, is already happening with COVID expenditures. So there is evidence in Britain that's about half the pandemic contracts that went for the pandemic spending, 22 billion, were awarded to firms with political connections, firms with no prior experience, and firms with a history of controversy. And this is Britain. I mean, this is because they started earlier, and so we have the data. And you also probably heard that in the last 6 months, we've had 5 health ministers in Latin America resign over COVID-related scandals. So this is happening as we speak, the capture. And those 5 guys in Latin America are the ones who got caught. I hate to think what's going on in some of the other countries where they haven't yet gotten caught. But now let me turn to primary health centers. So with primary health clinics, you would think, given the way where they're allocated, that would be a way to reach the poor by increasing spending on primary health centers. But there we run up against another kind of government failure, which is massive, which are the incentives to monitor people working in rural areas. So we have a huge problem with leakage. That is the money that is allocated to the primary health centers. We might think we're putting money into the primary health centers. They actually leak before they get there. And the extreme version is Chad, where the leakage rate is 99%. The amount of money that actually reaches the primary health center is less than 1%. And you can see why this has got to do with monitoring, because this is money mainly spent on drugs and equipment and things like that. Drugs are actually have 2 characteristics. One is that they're worth a lot in the open market, and they're easy to steal. You just put it in your pocket and you walk out the door. And as a result, they disappear from the clinics that they're where they're supposed to be given to patients. But the problem is not just the leakage of the drugs. We also have high rates of absenteeism of the doctors and the health workers in the primary health clinics. And in a range of African countries, we're documenting something like 40% absentee rates of health workers in primary health centers. And we find the same, and by the way, it's the same in India. If earlier work by Karthik and others show that it's about 40% in India as well on average. But there's yet another problem, which is that when the doctor is present in the clinic, remember, these are public doctors, and they're also trying to promote their private practice. So when they're present in the clinic, they actually try to rush their patients through so that they will come in the evenings to their clinics. And you see this in extremis in places like Tanzania. The average amount of time a doctor who is present spends seeing patients is 29 minutes a day. In Nigeria, the doctors see an average of 2.3 patients a day. Now, this is even more scandalous because you're basically denying people a free service in order that they have to go and get a paid service. So this is the system into which we're putting a lot of money into for health to fight COVID. That it could go into hospitals and get captured by the rich, or it could go into primary clinics and get wasted essentially because of the failure of monitoring incentives. Now, in this situation, what can be done? What can we do? And we can discuss for a long time, but I just want to give you two ideas that address these government failures that are worth pursuing, and I think will be echoed in some of the papers coming through in the IPF this year as well. The first is, if you've got a problem with monitoring, the problem with monitoring is that the central government or the Ministry of Health can't really monitor the doctors in the clinics or the nurses in the clinics. But there's somebody else who can, which are the people in the community. And that's what now there's some evidence, not universal, I should add, that there's some evidence that some kind of community participation in monitoring the clinics actually leads to better outcomes. So there's this work by Jakob Svensson and Martina Björklund in Uganda, where they introduced a system where they'd hold town meetings like this one here to ask the local villagers what they wanted from the clinic. And then they would translate that into a compact or a contract that they would take to the clinic, and the clinic would agree to providing those services, and these would be monitored by the community on a 6-monthly basis. And they did a randomized control trial so that they had, a treatment group and a control group. And what was interesting was that this experiment led to, in the treatment group, to an improvement in utilization of the clinics, greater effort by the health workers, and significantly, an improvement in child mortality. So this is one of those cases where the experiment actually led to actual improvement in health outcomes down the road. Now, this can help on the monitoring side to address that government failure. Well, how do we address the political capture, the elite capture that we're seeing throughout the world? And the only thing I can think of is that we have to find some way in getting the voice of poor people to be amplified in the political process. The reason why we have a problem is that politicians can cater to the non-poor, to the rich, with healthcare, and get elected and reelected, because poor people, for various reasons, may not vote for them based on the quality of services that they're receiving. So here's one big case for transparency of data, making sure that poor people as voters learn about the quality of the services that they're receiving and be able to connect that to the performance of politicians. That's so important in the context of countries like India. But there's another side to this, which is kind of interesting, which is that we observe one other way in which poor people don't vote what in their best interest in terms of health, say, is if there's vote buying. So politicians offer them money to vote for them. Now the question is, how does that ever work? How do people monitor whom you vote for? It's a secret ballot. Well, it turns out that if the ballot is a paper ballot, and we've documented this in Philippines and various other places, there are election observers who literally are watching whom you vote for. And that way, they will vote for whoever paid them money rather than who is going to give them the better services and the quality services. Now, Tom Fujiwara has done this very interesting paper where he looked at the changes in the electoral system, which is when they introduced electronic voting. When they introduced electronic voting, you can no longer observe whom people are voting for. And this simple change of introducing electronic voting seems to have enfranchised the poor voters. So you find that the introduction of electronic voting actually led to an improvement in various intermediate indicators of health outcomes, including prenatal visits and an increase in health spending. So you can actually increase the voice of the poor through various means in order to achieve in order to improve health outcomes and overcome some of these government failures. Now, there's a silver lining to this in the case of COVID, because one of the reasons why this dysfunctional health system for the poor can persist is that the very top leadership in many of these countries, when they have a health problem, they go overseas. they go to Europe or the United States or anywhere else. Now, what happened with COVID was when the leadership got sick, they couldn't get on a plane and they couldn't go to Europe. So all of a sudden, in Africa, in many countries in Africa, they had to start using their own health systems because they had no choice. And then they started realizing how bad the current system was. So it was bad for everybody for a long time, but now the leadership has to pay attention to it. And I think this cartoon in a Nigerian newspaper captures it very nicely. You know, the politician says, no, don't take me here. I'm a politician. And they said, well, yeah, but it's your project, sir. Okay, so now let me turn to another area when going back to what governments are actually doing. And that area is education. And this is, of course, Rukmini's area as well. And there's a lot of concern and so lots of reports being written how school closures are going to affect students' learning. Because a lot of these children cannot study remotely and so on. But the fact of the matter is that in many of our countries, in South Asia and in Africa, the children, when they were in school, were not learning very much. Just to give you a couple of examples, in Kenya, Tanzania, and Uganda, the students were told the name of the dog is Puppy, and then they were asked a question like, what is the name of the dog? And in third grade, 3/4 of the students could not answer the question. In rural India, about 2/3 of the students could not do a 2-digit subtraction problem in third grade again. Now, keep in mind, these children are going to school every day. The enrollment rates are almost 100%. So what's going on here? Well, I think we know, and Karthik's and Jeff's work has shown this quite admirably. We have huge problems of government failures in education, both on the side of political capture and on the monitoring incentives. One is the absentee rates. So there's a lot of talk about teacher absenteeism in India, but it's even higher in Africa. Both the teachers being absent from the classroom and teachers being absent from the schools. But I want to turn, we know that this is not just simply a monitoring problem, it's also a political problem, that teachers are often running the political campaigns of the local politicians, and then the politicians turn around and give them a job for which they don't need to show up. But there's an even deeper problem, particularly in Africa, that we're finding, which is that when the teachers are present in the classroom, it turns out they don't know very much. So they've done these surveys now, not of student learning, but of teacher aptitude or teacher knowledge. And it's pretty scary because they had a very simple question. This is in a group of African countries. The simple question is, does the 4th grade teacher have 80% of the knowledge of a 4th grader? So do they know as much as you would expect a 4th grader to know? And it's only 66% of the teachers actually had that knowledge of a 4th grader. And you can see that there's a range with, in Nigeria, it was 26%. That's completely different from asking the question, does the teacher have the minimum knowledge for teaching? And it's the same thing with the mathematics knowledge as well. Now, what this tells me is that the appointment of teachers is it's not a merit-based process. It is political patronage. So that the political system has captured this education system. And they're given jobs that they're not qualified to do. In fact, they're given jobs for which they don't even know as much as the students they're teaching. And yet the system persists. So this is a very serious problem. Now, what do we do when the students are out of school because of COVID? And so here, and I want to say, I prepared this lecture before I knew that Rukmini was going to be the chair, but I do want to say that there is some hope by looking at this program called Teaching at the Right Level, TARL. Now, this is a program that Pratham and others have promoted, which is you group students in different grades and put them together if they're learning at the same level. So you take the second graders, third graders, and fourth graders, all of whom are learning arithmetic at the same level, and put them together. And it turns out that when they do this, the learning outcomes improve dramatically. So there's a whole range of experience now with TARL in different countries, different settings in India, South Asia, Sub-Saharan Africa, and Chicago. The results are quite impressive. Now, where COVID comes in is that when the Pratham people tried to introduce this TARL, there was resistance from the formal education system, the government education system in India. And they actually introduced it by teaching the children outside school hours or during their vacations or weekends and things like that. Now that the children are out of school, we might be able to introduce TARL, on a more widespread scale, because there's no regular day in the school. So this is an opportunity to actually promote TARL on a mainstream basis. This is one thing we could do. Now the other, which is a much more controversial point, is that the sorry state of education, of learning in so many of our countries, has led to a proliferation of private schools. And these are low-cost private schools, middle-cost private schools, high-cost private schools, a whole range of private schools. There are cities in urban areas in South Asia and in Africa. It's about 50% of the enrollment now is in private schools. And this is controversial, but it does tell me the importance of the private nature or the private good nature of education, that parents are willing to pay, even poor parents are willing to pay to send their kids to private school because they're not getting education in the free public schools. Now, but these private schools have been criticized, and correctly probably, because some of them are charging huge fees and milking these parents who are desperate to get their kids an education without necessarily providing quality. They just don't know. So they think, well, private school, they probably teach in English, we'll send the kid there, but the kid doesn't really get much of an education. But the solution is not necessarily to suppress these private schools, but to regulate them in such a way that they actually provide quality. And this is an experiment that Jishnu Das and Tahir Andrabi and Asim Khwaja did in Punjab, Pakistan, which was simply to publish what they call report cards, which is information about the quality of the school in terms of how students do on tests and the cost of the school. So you just give the whole range, the high cost, the school's cost and the quality. So you allow parents to actually choose where they want to lie on that curve between quality and price. And the result was quite surprising, that just publishing that information, getting it out to the parents, actually brought down the cost of public schools, of private schools. Not only did it bring down the cost of private school fees by 17%, it increased test scores across the board and increased primary enrollment by 4.5%. So this was nothing but the pure information, again, that was made available, but it was rigorous information that actually had a favorable effect. Okay, I'm probably running out of time soon. Let me move on now to the other area where governments have been intervening big time in the context of COVID, which is in social protection. And again, this makes perfect sense. In South Asia and Africa, the majority of workers are in the informal sector or casual workers who really can't work from home. The kinds of jobs they do are not conducive to sitting on a computer and working from home. And as a result, they basically lose their livelihoods. They lose their jobs in the wake of COVID. Now, governments have quite rightly, across the board, said, okay, let's compensate these people some way or the other for the loss of livelihoods, the loss of earnings as a result of COVID. And you've seen a proliferation of social protection programs around the world. It's now something, over 200 countries that have introduced social protection programs for COVID, and the number of programs is in the 3,000 range. Now, this makes perfect sense. Again, these people have been hit with an adverse shock. They really can't do much about it. So let's compensate them. The trouble is that social protection programs as well are easily captured. And let me illustrate that with an example from my own country, from Sri Lanka. I mean, Sri Lanka is considered this paragon of social welfare and everything else. And it had its major social protection program, cash transfer program, which is a program called Samurdhi, which is the largest program in the country. And then people have studied the Samurdhi program and what it's done, and the impact is pretty frightening. Sri Lanka's poverty rate was about 20% at the time. And what they found was that only 30% of the Samurdhi payments went to the poor. That is, 70% of Samurdhi payments went to the non-poor. Furthermore, of the poor, only 63% actually got the Samurdhi payments. In other words, there are 40% of the poor who were excluded from Samurdhi. Now, what's going on here? I mean, and this is Sri Lanka. This is supposed to be a success story in poverty reduction. Right? Well, there again, there's some evidence that the Samurdhi payments were delivered not just to the poor, but to those villages and those districts which were likely to vote for the party in power, the incumbent party. Because if you map the Samurdhi payments by the percentage of votes that went to the PA, which was the incumbent party at the time, the People's Alliance, you found that if you had voted around 50%, between 40 and 60%, that's when the Samurdhi payments were highest. And if the district was if the division was either very low or very high, they didn't bother with the Samurdhi payments. And there's anecdotal evidence that the people actually delivering the payments were pressured not to give it to people in these districts and to make sure they went to the people in other districts. And this happens around all over the world. The capture, again, this is using what are poverty alleviation funds to promote political interests. Now, what can you do here? Well, there is some hope with technology. See, instead of having this money delivered through these intermediaries who can then be pressured to give them only to people in certain divisions, you send the money directly electronically to the recipient. And now with cell phone penetration as it is in these countries, we actually can do that. And there's been some work by Alan Gelb and Anit Mukherjee that look into what is the state of these JAM, this combination of mobile banking, unique ID, and phone coverage. And you find that in several African countries and in India, there is potential for using this for social protection payments in such a way that it won't be so easily captured. So finally, let me end by going back to the first point I started with, which is regulating behavior, the way people, trying to get people to stop their, to wear masks and reduce social mobility and wash their hands and so on. And that, is incredibly important. And it does take government to actually enforce that, because as I showed earlier, there's the private incentives are not sufficient to achieve that. The trouble is that the way we have tried to regulate behavior in the COVID case is sometimes unrealistic. There was a WHO guidelines about washing hands and keeping social distances for the whole world. And my colleagues, Martin Ravalian and Dominique van der Waal and another colleague, looked at which countries in Africa, or who in Africa can actually follow the WHO guidelines. And it's what they call the Household Environment for Protection in Africa. And they developed an index, this HEP index, which is the percentage of people who actually have what is needed in terms of social distancing and washing their hands and so on. And even in the richest quintile in Africa, the HEP index is about 15%. And in the poorest quintile is 0. So virtually nobody can actually follow those WHO guidelines. Now that said, I don't think that's the biggest problem. I think the biggest problem is actually there might be guidelines that people can follow, but they still might not do it because of who is giving the message. And this is where this comes through very clearly, that the messenger may be as important as the message itself. And these are countries where there's, shall we say, limited trust in government, particularly in central government, or even remoteness from the central government. And the analogy I draw is with the experience with the total sanitation campaign in India. I mean, some of you may recall the first round of the total sanitation campaign back in the early 2000s, when India spent a lot of money on giving out free toilets to everybody they could find, and yet the level of open defecation did not come down very much. In fact, it stayed pretty much the same. And then what they found was basically that they gave these toilets and people started using them for purposes other than those for which they were intended. People started using them for grain storage, and there's a picture of a family using them as a puja room, and other things. Now, the interesting thing is that next door in Bangladesh, there was a very successful total sanitation campaign around the same time. Now, the difference between the Indian campaign and the Bangladesh campaign was that in Bangladesh, the toilets were handed out by the community itself. Basically, the government gave the community the right to allocate the toilets. And the community also ran an information campaign around it. And there is, again, rigorous empirical evidence that this combination of the community level subsidies and the information campaigns made the difference in Bangladesh. And so this tells me that with COVID as well, you want to have the messages delivered at the community level rather than from the national level. And so let me end with one example, a really delightful example of a campaign in West Bengal done by Abhijit Banerjee and several co-authors, where they actually sent around an SMS audio clip, 2.5-minute audio clip, using Abhijit Banerjee's voice and the fact that he's Bengali, speaking Bengali, encouraging people to wash their hands, to maintain social distances, and report symptoms to the local health clinic. And then they did a randomized control trial where some of the messages didn't have Abhijit's voice in them, and some of them had different messages in them. And you found that there was a statistically significant effect of those who received the Banerjee clip with the messages delivered from a Nobel Prize winning son of the soil from West Bengal. And people say this is one of the few cases where Abhijit Banerjee was his own instrumental variable in his own paper. Okay, so let me stop there. Just to give you some conclusions. So COVID-19 is going to involve massive increases in public expenditures to treat victims, mitigate education losses, compensate the poor, and slow the spread of the diseases. But we have to keep in mind, for a large variety of market and government failures, mostly government failures, the public expenditures have not been particularly efficient nor equitable. And these reasons have to do with incentives in the public sector and the opportunity for political capture. But there's some evidence, some recent evidence, that things like community participation, transparency of information, and the political participation of the poor can lead to better public expenditure outcomes. And this means that we have an opportunity first to make COVID spending more pro-poor and effective, but also pave the way for a more effective and equitable public sector in the post-COVID era. Thank you.
Shanta, that was fantastic. Many issues to think about and questions. But I will take the privilege of being on the stage with you to maybe ask one or two. If I look at education, which is probably the only thing I can really look at, the COVID crisis has clearly demonstrated to us that that there was a big crisis before, and so it's not like this crisis has led to the situation. But certainly this last year and a half has, I'm sure, made things worse. But that this current situation, we cannot go back. If we are in our right mind, we cannot go back to operating like we did before. And the example, Sonal put a very good example in the chat, which is absolutely true, that today in July 2020 in India, the children who are so-called enrolled in Standard 2 have actually never been to school before. And therefore have had no preschool, no schooling. And clearly the curriculum, which has been, according to many of you, and some of you are here like Lant and others, it is the curriculum which has been the problem in the past, will not work now. So you have to start if you want to think about the child, which all school systems, I believe, should, although in many cases in the Indian education system, we've been thinking about curriculum rather than about children. We have to do things differently. Teaching at the right level, which, we have evolved over a long period of time and has been intensely evaluated for 10 years. There is evidence which points to the fact that doing things like starting where the kids are, whether they're in second grade or fifth grade, starting at their learning level and moving forward will work. And you are hopeful that evidence will lead to a different way of doing things. But let's say that the education sector is in one place. Is there similar trends in health where you have to completely redo the way you're thinking, especially if we think about how is, the third wave apparently is coming, or even if the third wave doesn't come in the way that the second one came, COVID is here to stay for a while until we are all vaccinated, and then maybe there will be other variants. But in the health sector, apart from the fact of, expenditures being the way they are, do you see a complete rethinking that needs to be done? Not just expenditure, but the way the entire system functions. Any quick thoughts?
Okay, wow, thanks. Those are two very big questions. But I like those. I like the point about education, and it gives me a chance to mention something. You see, I may have been a little cavalier by saying, well, the children weren't learning much when they were in school, so being out of school may not be so bad. But in fact, it is actually quite bad. And one of the reasons is that when they go back to school, there may be permanent learning losses that are exacerbated by the fact that the children get promoted whether or not they have learned. And I'm drawing on a paper by Jishnu Das and a few others about the Pakistan earthquake, where they find the same result. I mean, they looked at what happened to people depending on how close they were to the earthquake epicenter. And they find that almost on other dimensions like income and so on, there was no difference depending on how far away you were. The big difference was in education, where there seemed to be permanent learning losses of the children who went out of school. And the thing they found was that these children kept getting promoted even after they went back, even though their learning had lost. And so they fell further and further behind, and they became more and more discouraged. And that is exactly, and that's why I think TARL, teaching at the right level, is a good opportunity to really rethink this whole promotion point, because that is the other side, right? The reason the children are not learning at the right level is because they've been put in a class that they don't really belong in. So I think this is definitely something to capitalize on. Now on health, to be honest, I don't know of any, something like TARL for health. And the reason is that the politics and the capture is just so profound in the system, and I can just see it happening as we speak. That the combination of wealthy doctors and wealthy people can easily capture all of this additional income. So I would say two things. One is this community level monitoring, or some kind of monitoring. If we're aware that the hospital spending is going to be captured by the non-poor, then we should scrutinize it even more carefully than we normally do. I think that's really all I can say at this point. I mean, others might have some suggestions.
So I want to just, in the spirit of keeping the conversation going, one of the reasons that we have the learning crisis as we do, and the numbers that you showed are absolutely true, whether it's in Africa or in India, the fact that by third grade or maybe even by second grade, the proportion of children who are at grade level can range anywhere. I mean, in India, third grade being at grade level pre-COVID ranged from 40-50% in some states like Himachal or Kerala to 10% or 12%. And I think many of you have said this, and Karthik says this very vehemently in a Karthik-like fashion, that we are really a filtration system. The education system is really organized to filter out and just take just those kids who are at grade level through the system. And I think in that sense, COVID provides an opportunity to maybe, and our new education policy provides an opportunity to reset, to say, are you going to be a filtration system, or are you really going to give children an opportunity to learn? And so there is a real, individual, small, elite excellence versus an equity that has to be addressed. If it's not just, schemes and so on, and I think probably health is like that. But I want to raise one more question, both for you, Shanta, as well as for others in the audience, that we know that a large number of Indian children, even in rural areas, were attending private schools, low-cost private schools, where the margin of kind of survival has been quite low. And it's likely that many of these enterprises have shut down. And so there is going to be a huge need in India for helping children catch up, in their basic academics, including trying to bring private school children back into some level. Now, in terms of public expenditure, do you feel that in this kind of a setting where there has been a huge crisis, but in that crisis, at least as far as primary education goes, there are quite simple things that ordinary people can do, which perhaps are not possible in health? Do you think something like the Narega could be opened up during a COVID period, perhaps for the remainder of the school year, to really help at the community level to help children catch up and build back, both dealing with children who are in the government schools who fell back, and from private schools who've had probably no exposure especially the low-cost private schools, to any kind of learning opportunity. Is this something that other countries are doing? Is this something that should be tried in India? So that you can get back to this idea of shifting from sort of, individual and elite excellence towards equity by a big pumping of public expenditure.
Okay, 2 points on that one. One is there is some hope with COVID that this filtration model cannot survive, because it's part of a broader model where you can basically ignore inequality, right? You can tolerate inequality in your society because what you care about is the elite, well-educated, smart kids who are making it and going to the IITs and God knows where else. The thing with COVID is because it's an infectious disease, you can't ignore it for the poor. And this came home to me in of all places, Singapore. Singapore was very proud of the fact that they had managed to withstand the COVID pandemic until something blew up in the migrant camps, the camps with the migrant workers. And basically, then they started realizing how horrible the conditions were for these migrant workers. But the reason they realized it was because if there's a pandemic that breaks out, if the epidemic breaks out in the migrant camps, it could spread to the rest of the population very quickly. So there's again another silver lining here that we can't ignore the inequality in society when there's an infectious disease. On the NREGA point, I don't know any specific programs, but I think there is a move around the world now, and USAID may be at the spearheading this, which is in all of these expenditures, let's ask the question, before we do a program, can we have a bigger impact by just giving them the cash equivalent? And this is very powerful, actually. It doesn't mean you have to do that. But if you put that as a standard, that you have to show me that this program is better than giving them money and letting them do what they want with it. That can be a way of shifting the balance. And this may be a way to do what you're saying, Rukmini, which is, let's get these kids who are out of school and give their parents some money and let them figure out how best to help them rather than some complicated government program with all of its procurement possibilities and so on.
Great. So I think by arrangement with Rukmini, she wants me to take over the questions and calling people. So Shanta, let me, first of all, thanks so much for the lecture. And it's gratifying to see how many of the themes you talk about have actually been topics of IPF papers. This simple point you mentioned about cash benchmarking was something Matrish and I wrote about 2 years ago in our IGD paper. And the more fundamental point that you talk about public health versus curative health was, featured in Ajay Shah's paper last year. So I think my simple question to you is, I think economists have been screaming this from the rooftops, that about the centrality of the returns of preventive public health being so much larger than the returns to curative private health. But that just doesn't seem to be getting through, right? So there is something about a politician's instinct to need to show that you've done something to directly alleviate somebody's visible problem. So it was ventilators last year, it was oxygen this year. And these are all important, but they're still at the end of the day kind of private goods that are solving problems for one person, as opposed to using this pandemic as a chance to really reset our public health expenditure towards public health that would have a much higher return. Now, but this is not just India, right? This happens in many other places. So I guess the main question I have for you is, we know the facts. What would you say are the best chances to get the political class to listen to this basic message? And, and we keep repeating this at the IPF, but not much seems to be happening.
Okay, this is a deep question. I think the first thing is, let me add this is still at the diagnostic level. This work that Pascaline Dupas has been doing, I think, is very informative here, where she characterizes that the problem with developing countries in health is that before they could set up a well-functioning health system, a whole lot of technological advances appeared, because that's what developed countries were at the stage of, although they had already set up their health systems. And as a result, the developing countries couldn't resist just grabbing onto these gizmos, as you were saying, the visible advantages, at the expense of strengthening the health system. So we're caught in a time warp where these inventions came up too quickly for the developing countries. They came up at the same time as developed countries, but I mean, in the right time for developed countries, but since technology diffuses quite quickly, they are actually creating a distortion. So it's a very hard problem. How do you tell these doctors, do not use that heart-lung machine, because that's taking money away from actually improving the water system so that the children don't die of diarrhea. So I think we need to take a step back and ask, and that's where I would say we need to start embarrassing the politicians. This has to be, health cannot be something we're polite about. Even in India, I've attended dozens of meetings where people will present the public health program and everything else. And that this is nothing but a transfer to the rich. But I felt like we were all being too polite, because how can you be against health? And these are doctors working really hard to try to save our lives and so on. But this is, and this is even more difficult during COVID. But I think this is the time to be vigilant about it, because if we can't reverse it, we're just going to be in the same problem over and over again.
Thanks, Shanta. Let me call on Suman.
Suman, you're on mute.
Karthik, well, I wasn't actually. Karthik, no, you're no longer in the international organization, Shanta. So let me just ask you, a large, not enough, but still a large amount of money is being directed by the international organizations to address COVID. Okay, so both in terms of innovation, but also asking these tough questions about who is benefiting, what more should and could the international organizations do? Or are they also captured by the elite and therefore essentially ineffectual?
Yeah, no, I think that the problem with, I'll be specific, the problem with the World Bank, but it does cover some other international organizations too, is that they measure their self-worth in terms of the volume of dollars that they lend. And that's the root of the problem. So when COVID hit, David Malpass says, we're going to lend $160 billion. Didn't say we're going to actually cure people or we're going to save so many lives. It was, we got to, and every progress report is how close are we to this $160 billion limit.
So you're saying basically log frame and IEO and all of this, that's just window dressing.
It's complete window dressing. And I would say just ask the question, have you heard of a speech by David Malpass that doesn't mention the 160 billion? Or it does mention, I mean, it really is interesting that slide I put up about social protection programs. That was one of the most useful things the people at the World Bank did, which was they documented on a weekly basis the social protection programs that every country is doing. And they published it on the web every week. It's tremendously valuable, and countries would exchange notes and everything else, right? And I tried to, even though I'm an outsider, I do talk to these guys. So I tried to get Malpass to actually talk about it in one of his speeches. You'd think that this is one of the most useful things the bank is doing. And the question came back, well, so how much lending are we doing in social protection? Which is very little, but that's not the issue. So the results, this results framework, and by the way, it's the same thing in India, right? I mean, it's the same way India looks at its public expenditure program. It's how much money we spent rather than what did we achieve from it.
Thanks, Shanta. I think we have time for 2 more questions. I'm going to take one question from the attendees that's been typed in. So from Sandhya Garg, the question is, as we see that the impact of COVID has been severe for developed countries as well, so how do we view the government failure there? Are there similar problems there, or are the problems different? So I guess, just adding my own editorial point to that, because there is this very tricky issue of benchmarking, right? So how much of kind of the problems we face in India are sui generis and things that we should be especially up in arms about, versus this is just a once in a century pandemic and the whole world is suffering. And so it would, how do we do that benchmarking, right?
Okay. Yeah, actually that's those are 2 different questions, but anyway, that's okay. No, I think, as I was trying to show, I think many of these problems are also there in the developed countries. Mm-hmm. This potential for political capture of pandemic funds is quite widespread. Mm-hmm. And I mentioned the case of the UK, where 50% of the procurement went to these questionable firms, and we're seeing these things come up in the US and various other countries. But I would say in 2 ways. One is the stakes are much higher in the developing countries. You're going to lose a lot more people if you let this happen in the developing world. And the second is, in the developed world, this might be a temporary shock. That is, you do get this big surge, and then it's going to go back down. Whereas what I'm concerned about in the developing countries is that this is going to do some permanent damage. It's a little bit like what we're discussing with Rukmini about the children not being able to go back to learning. So the case for looking at it in the developing world is just much more serious. Now, your benchmarking question, well, I guess that is similar. Then is that I really don't think we should think of this as a once in a lifetime or once in a century pandemic, and then we'll go back to steady state, because steady state is not acceptable, first of all, and never was. And secondly, it might actually be a lower steady state than the one we started out with. So for both reasons, we need to go back to these fundamentals and try to resolve these government failures.